So it is my privilege to welcome you again to this 1, 2, 3 edition of Thursday Musings, genetic testing in psychiatry and how do we go about it. Uh, we'll follow the old protocol. The audience will be on the mute mode. Panelists can unmute themselves. Questions will be invited in the chat box. The recording will be available for later viewing. So next slide, please. So I'm handing over the session to Professor Dr. Tufan Pati, sir. Sir is from Cuttack, chairman of this program and very busy nowadays, extremely busy, but still finding time for us. Sir, please do keep guiding us and over to you.
Thank you, Aleem, very much. Thank you, realizing that I'm little busy, not very busy. And with that little business, I will always find time for Thursday musings. And get ready, 1, 2, 3. This is 123, third episode of ours. And I have the pleasure to reiterate that we have got two vibrant moderators, and let me briefly introduce them. Next slide, please. Dr. Amrit Patadosi, Professor of Psychiatry in High-Tech Medical College, Bhubaneswar, and Direct Council Member of IPS. And he's also Honorary Secretary of IPS. He's June. Next slide, please. Dr. M. Alim Siddiqui from Lucknow, Nawabaki Nagari, Professor of Psychiatry and Head of ERAS Lucknow Medical College and Hospital, Lucknow, and currently Honorary Treasurer of IPS and guest faculty in Amity University and Editor-in-Chief of Indian Association of Biological Psychiatry. Welcome, Dr. Amrit and Dr. D. Next, please. I have the honor to introduce our illuminary chairpersons, Dr. Asutosh Shah, Consultant Psychiatry is HN Reliance Foundation Hospital, Mumbai. He is into psychiatry since 1999. A special interest include mood disorders, schizophrenia, and dementias. Welcome, Dr. Shah.
Thank you.
And I have pleasure to introduce Dr. Malay Dave. He is quite well known in this platform. Welcome, Dr. Malay. He is consultant psychiatrist and in private practice. He was awarded the Bombay Psychiatric Society Silver Jubilee Prize and Bhubaneswar, January 1999. Again, it is going to be 2023. I think you are there. Won Dr. Neil Bishop Best Paper Award in 29th Francis Vaichan Branch, Mumbai, October 1990. These areas of interest: neuroscience, genetics, 12 publications to his name. Welcome, Dr. Rave.
Thank you.
Now onwards, the meeting is chairpersons. Shimon, please introduce Dr. Sydney, and the other please introduce the topic, and thus we move on. Welcome. Over to the chairpersons.
Malay bhai, can I do the easy job of introducing Dr. Sydney?
Yeah, sure. Please go ahead.
Okay. So most of you know Dr. Sydney Morangtham. Is that the correct pronunciation of your family name?
Yeah, so it's perfect.
Thank you.
In one go.
And we all know that he is a loyalist of Nimans, but he's also an additional professor of Nimans. And he's done his MD Psychiatry from PGI Chandigarh, another prestigious institution, in 2007, and then had a postdoctoral fellowship in the year 2016 from US. And his current areas of work and research are on bipolar disorders, epigenetics, emergency psychiatry, forensic psychiatry, and telemedicine. And to lay the, I would say, floor for his presentation, Malay bhai, if you could share some words on that.
Yeah. Good evening, everyone. Thank you, Dr. Alim, Dr. Amrit, and team for inviting both of us to chair this session today. Very interesting session, and that too by none other than Dr. Sydney. We have had and we have been having and will continue to have a lot of debate on how exactly genetics is placed vis-a-vis psychiatric disorders. What do we need to look at? How do we go about it? How do we put it across to our patients? And more importantly, how do we kind of reconcile? How do we kind of integrate all the knowledge that is there, the newer research findings, into our understanding of psychiatric disorders as we understand themselves? Theoretical discussion is one thing, but when it comes to the actual clinical aspects, the bedside experience of genetics in psychiatric disorders or neuropsychiatric disorders, it becomes a bit of a tricky issue, because genetics in psychiatry is not it's not a single line or a linear kind of a thing. There are too many things involved. There are too many aspects that we still do not know of. And well, if we understand little, what do we make our patients understand? How do we go about counseling them regards this aspect? And to enlighten us on this topic, we have Dr. Sydney today. And without taking anybody's time, including his time, over to you, Sydney. All the best.
Thank you. Is the slide visible?
Yes, you can go full screen. Yeah, full screen visible now.
Good evening, everybody. First of all, please accept my apologies to the Mussing team because this talk was supposed to be done last week, but because of some health condition, I could not do it, and I have to literally force Alim to cancel it at the last moment. And again, I thank them, the whole team in Mussing, for giving me another opportunity. And the topic that we are going to do today, I'm not going to talk much about the techniques of genetic testing. I think that can be a topic for another day, or we can have another forum for that. So here it is more about what do we do when we are put in a circumstances where we feel genetic testing might help, but what exactly do we do? So my presentation will be slightly unconventional. Please bear with me. The first couple of slides, I will run through some of the theory that we already know about psychiatric genetics, like Pradhavi has already pointed out. Yeah, we know that this time there are sufficient evidence to say that many of the disease we understand as today has underpinnings and seems to be fairly heritable. We use a lot of terms like copy number variants, single nucleotide polymorphism, genome-wide approaches to classify some of the mutations or some of the changes we understand, or some of the approaches that we use if should we ever start the genetic testing of an individual of interest, in our case, a patient. Why are we doing it? The first sentence of the second slide is a little controversial, but I think this is what we need to expect, or rather, this should be the way forward. I mean, when we had ICD, the earlier ICD, DSM-3, and this one, the earlier iterations, we really don't understand. I mean, at least the forefathers or the scientists of those days tried to classify the illness that we know today as bipolar, schizophrenia, based on some symptoms or phenomenologies. Not the best way, but that was what we have. But when we try to look into so-called etiology-based classification, as we have in other specialties, there is always a significant, should I say, lack of biological underpinnings, which the current iterations of DSM and ICD can say. I mean, this is what it is. We are limited. We have to understand that. But at the same time, no matter how much we say that, okay, psychiatric genetics, proteomics, transcriptomics, are we really there to entirely replace them? No, not yet. I mean, we are in a transition stage. Maybe it will happen the next decade or a little bit more than that. So the intermediate is when NIMS decided that, let's try to go to research domain. These are all theoretical. This is the side where they have tried to give some link, right? Then, yeah. When we talk about testing in medicine or any other disorder, we are very pretty clear what is the variable that we are measuring, some quantifiable things like hemoglobin or the ability to hear in terms of decibels, hearing loss. But we really don't have that in psychiatry. I mean, we cannot measure hallucination with any of these modalities. So what are we actually left with when we say testing? They're also genetic. These are some of the standard indications which was depicted in one of the earlier papers which I've referred. I've said in the reference. Still now, I could not find much changes in the indication in the past 5 to 6 years. Essentially, it has remained the same. Yes, a lot of commercialization, or rather, commercialization sounds a little bit gross, but maybe the ability to predict a drug response has been one which has received a lot of attention, at least in the way that some precision medicine can be done. Then the second and third is what we already know, some metabolic disorders which we read in medicine. Then our area of concern when it comes to our core disorders, schizophrenia, bipolar, is the main test. It is to see whether the variants carries some risk for a brain dysfunction. The fourth one. Okay, I'll just run through this slide. This is with what we can say the history of psychiatric genetics, what usually with people do in the beginning, from sensor sequencing to first generation. It is when the GWAS came, thinking that there will be a mesocyte, some candidate genes. That it is just to say the technology has evolved, but they have their own limitations, and hence, the first generation sequencing could not answer much, and it was very, very difficult to reproduce. The results were mostly negative, and but something we understand is how the receptors function, the synthetic functions of the neurotransmitters in a system. Still controversial though. The next generation sequencing is what we do now, and they are used for neurodevelopmental disorder like ASD, early onset neuropsychiatric conditions, or some disease which can be de novo, or when we suggest or when we suspect that there might be this one, some genetic error, we don't know what, in the family member which is responsible for the presentation of the person who is presenting to us as a patient. Right. So these are some of the techniques which are most commonly used these days. The whole genome sequencing, very robust, very, very extensive, and it gives a lot of things, a lot of data, but the cost is very expensive in India, even though it has decreased, but still very expensive. So the slightly easier option is the whole exome sequencing. This is what I'm going to emphasize at this point of time. It looks at the exome, the protein translating part of the gene, and usually it tries to follow a Mendelian hypothesis, one gene, one disease, but even in psychiatric genetics, it is still relevant. And this is one of the tools which we has been using very, very frequently. Then microarrays are for DNA segments, or rather say segments which are big, which may not be necessarily detected by our exome sequencing, and they also play some role in disorders like schizophrenia, some ASD, some developmental delay, without specifying where. Okay. Then these are techniques which we are currently using, which tries to give some meaning to the pathology which the patient is presenting. In the process, we try to change the nosology. So some group of workers finally thought that, can we do what is known as reverse phenotyping? Can we associate symptoms? Because if we take two examples, bipolar and schizophrenia, their genetic homology is almost 99%, but the symptoms are very, very different, or it can be similar. So why don't we try to base the symptom based on the genetic profile? It is one way forward, not really there. I will just run through the drug response because this is what we already knew. The pharmacodynamic is a process in evolution. This is more epigenetic based, and this is not really different from, to be very honestly saying, okay, what is the epigenetic mechanism of an antidepressant or an antipsychotic based on their epigenetic properties, and what do they actually do to the receptor or to the molecule in questions. Serotonin is quite famous, so that's it. From here, I will try to go a little different for this topic that we are discussing today, because I think rather than going too theoretical, explaining about this technique, what are the limitations, what do they cause, what do they can do, how many papers are there, I think it will be better if we just sail through some of the difficulties we have come across in this particular case veneers, and it will try to explain what have we experienced, and with anybody, any of the people listening or other in a similar situation would be doing. Okay, we had presented this case to our department before briefly, and I thought this is the best way to understand what are the logistics difficulty or the challenges, or rather the beauty about how do we handle a genetic test and their results in a patient who is mentally ill. So the case BDA is basically about two twins, about 23 years old. They have managed to finish, as far as I remember, some graduation course in administration and law. They are unmarried. They belong to a upper socioeconomic status. They are Hindu by religion and from Eastern India. What is interesting is the timeline, because the timeline will also hint towards a lot of neurodevelopmental probably, or possibly de novo. We really don't know at this point of time. So the sleep complaints for both appeared at almost when they were in their 8th standard. It was around 9 years before they present to us. The first twin started with low mood secondary to repeated thoughts and difficulty in socializing. The second twin started straight away with repetitive thoughts and images predominantly for a similar duration. And in the past 5 years, there is a repeated desire for correction of facial appearance. And the second twin also started to have referential ideas and reduce social interaction and decline in self-care in these past 4 years. The trajectory of the symptoms are, in one way, we can say at this point of time, seems to be quite similar. The first twin, till 2013, had an average academic performance when they were in their 8th standard. So he experienced what are intrusive, repetitive thoughts, which looks like an obsessional thought. The theme would be right things in life, existential theme, but like a typical obsession or that we see in a patient suffering from OCD, after repeated interviews, observation from the ward, histories from all the family members, we could not find a clear-cut obsessional symptom, but nevertheless, it looks like it. Then he had disturbed attention concentration, crying spells more outside home and around people, but very less at home. So there was some slight academic decline. He had low mood, not really severe enough or persistent enough that we can call a major depressive disorder. We don't know the details of the earlier treatment, but he was treated briefly with medicine and therapy and remained well till 2018, which according to the family and the patient, 75% recovery. And from the period 2013 to 18, he had waxing learning courses. In spite of this, the boy completed his +2 here in Karnataka with, a reasonably good score of 80%. And by the time he had learned more than 3 languages, and same goes for the other twin. So that also was good till the 8th standard. Started having images which looked like an obsessional, again mainly out of home, again triggered by people. But he didn't experience an academic decline like the first twin and remained fairly well. But there is a slight change of phenomenology here. From 2015 for almost 2 years, he seems to develop what looks like body dysmorphic disorder, repeated checking in the mirror for nose, lips, but he was reassurable. During this period, no treatment was sought in the second twin. 2019 is when I came across them. Both twins have this one, relapse of symptom in greater severity. In addition, they had severe anxiety, social withdrawal, decrease in self-care, not meeting eye-to-eye contact, low mood, occasional anger, but does not express any fear or embarrassment. Again, not much elaboration of thoughts. No matter how much we tried, they were just not able to describe it. The second twin started to have referential beliefs, not bordering delusions, but again repetitive. But the fear is someone might kidnap him. So there is social withdrawal, the gradual decline in personality, decreased self-care, and most time they spend together in the same room. We also discuss about whether it's a shared delusion phenomenology, but when you take the history a little bit more intensely, you found out that these are distinct, separate set of psychopathologies which both these twins are presenting, but yeah, many of them are similar. Both of them completed the graduation online during the COVID times. That is when they were out of my trip. Okay, so 2019 to 22, the time of COVID, the initial treatment was in the first twin with escitalopram and amisulpride. Sorry for this one spelling error. There was some good initial response, but they plateaued out. The same happened with the second twin, sertraline, in low doses, amisulpride, and initial good response again plateaued out. Premorbidly, both of them were described to be slow to warm up style, but does not point towards any what could have been a psychopathology. No features suggestive of a gross ADHD, not much externalizing disorder or internalizing traits. So we, at this point of time, we were not very sure what we are dealing with, because both the appearance of symptoms for both was almost at the same time. The response to medication was almost similar, some initial response, then again it plateaued. So for the first one, we make a provisional working diagnosis. Are we dealing with a probable OCD mix because we might not be able to say the mental compulsion, even though at the cross section it looks like OCD with predominant obsession? Or is it a prodrome because both of them are exhibiting some decline in personality? Or is it some variant of an autistic spectrum disorder? So that is when the first twin was brought. The second twin almost had the same thing. So the initial diagnosis we kept was again OCD versus psychosis inverse versus schizotypal versus ASD. At this point of time, perhaps if they were handled independently by two different psychiatrists or two different mental health professionals, then we would have just dismissed it as maybe it is an OCD in evolution or it's a prodrome and leave them at it. But they are twins, and monozygotic looks almost the same. And the presentation of the symptom response was almost mirroring. So that is when we thought, okay, it doesn't seem to be what our ICD or the DSM says what is OCD or what is an ASD or what is a prodrome. We did a lot of investigations to rule it out to see what are we missing something. So both of them in their physical investigations had mitral valve prolapse at age 22. There was not much of a hemodynamic sense, but nevertheless they have it. For the first twin, the citalopram was increased to the usual obsessional dose that we use here, and amisulpride to the antipsychotic dose. There was again good response in third week and forward, again it plateaued out. The second twin had ptosis, refractive error, and bilateral hyperintensities in the periventricular frontal region. It was not small, it was big. We tried to see whether it could have been a probable perinatal insult because they were twins when the mother gave birth to them. So, but the parents ruled out any hypoxia. The pediatrician ruled out any hypoxia because they were from a very well-to-do family, delivered in a hospital, and the care was, according to them, quite adequate. But again, I mean, we kept all possibilities. A neuropsych assessment also says the same impairment, which is corresponding to the frontal region. That means frontal and right temporal involvement, deficits in planning, blah, blah, blah. And this. Again, same response to medication, sertraline, high cup, amisulpride, high cup. There was a response, then again plateauing. So that is when we literally hit the wall. I mean, when we are not sure, because first time there was a response, there was a plateauing. Then second time there is a response in a higher dose, again there is a plateauing. If we look at the family tree, I mean, we took a very extensive history for almost 3 generations, and this is the best we could get. So we found that a lot of relatives by blood, not by marriage, had multiple issues. Complications of childbirth, electrocution is what they describe. Whether that electrocution is accidental or intentional, we don't know. The kidney disease, suicide, opioid dependence, then depressive disorder, then OCD, then some death to MI, and death not attributable to known causes. So it's pretty typically what an average person with some interest in genetics will say what is called a dense family. There are too many family members involved. So that means there has to be some disease, disorder, known, unknown running, and what the twins are experiencing is probably a manifestation of some set of genes. When we trace back the history of the birth, the father was, I think, around 50, 55 when he gave birth to the twin. The mother was also not too young. At this point, what we thought is, what should we do? Because we have done the imaging, which has shown some finding in one of the twins. We have done the metabolic work. We have done the inflammatory work. They are all normal. So that is when we thought, okay, let's do a whole exome sequencing. So this is the result which completely baffled and surprised us. Usually in a whole exome sequencing, we find some variant which are clinically significant, or in both cases here, uncertain significance. They are not saying insignificant, uncertain significance, but we are finding two things. One is an SNB and indel. The gene is GDI1, which is X-linked, and it is dominant. And the second part is the interesting part. There is a syndrome which we came across at that point of time when the result came, White-Sutton syndrome. The variant, the chromosome 1 duplication has never been reported. So we looked through the whole genome database by the people in the lab and by the lab which has done that. And it's not just there. So this is the variant which we are reporting in both twins for the first time. So White-Sutton syndrome is basically a syndrome cluster classified, or rather characterized with predominant mental retardation. People can have some autism-like features. Some reports suggest autism-like symptoms. Some reports suggest some symptoms of psychosis, but never very clearly written, because many of the reports which are being published are either pediatrician, neurologists, or geneticists, very few by psychiatrists. But intellectual disability or intellectual impairment is what was predominantly reported. Luckily or rather, we really can't say it lucky, but at least lucky till now is that both of them seems to have an intellectual disability, because they speak more than 3 languages. They have cleared their graduation, and yes, because of the reappearance of some of the symptoms which they were experiencing in childhood, they were not able to continue more. So whether we can call it an intellectual impairment because of the illness or otherwise, but this is what baffled us. So this is when we are at a crossroad to see what exactly a psychiatric test or a psychiatric genetic test reveals. What is an uncertain significance? How do we explain it? Because if we were initially doing a working diagnosis of OCD, prodrome, ASD, blah, blah, blah. Suddenly it took a complete 180 look. I mean, the whole syndrome seems to be a part of what is known as White-Sutton. 100 cases are reported worldwide, so we'll try to find more. We are not able to test the parents yet. If we have to share the current status, then I will explain why we have done what we have done. The first twin seems to be a little bit, initially was better than the second twin, which seems to have a predominant, some psychotic symptoms. His improvement in the last few weeks were much better. Both of them are doing well. Their daily activities are re-regulated. The only thing which we have added, in addition to the antipsychotic and the antidepressant, was a very high dose of L-carnosine and a lot of gut bacilli. Prognosis, it is uncertain, because none of the literature says what actually happens to Sutton-White syndrome. And both of them had a mitral valve prolapse. Whether this is going to be a stable deficit or this is going to progress, we don't know. I mean, this is for time to settle. And the diagnosis we have kept into in evolution. I mean, this is how much our ICD and the DSM does not match with what we can have in some genetic tests that we do. Okay. Then the next question we need to answer is, why did we do the whole exome sequencing? There is no fixed guideline or hardcore guideline. Some will say another, some will do it, but the reason we choose particularly is why is there a plateauing to the response to medication? What is explaining the worsening of the symptom in decline in personality, but not the degree of dysfunction which we otherwise see in a person with progressive OCD, progressive ASD, or progressive psychosis. They are distressed, but the trajectory is not just following that one. There is shared phenomenology in both cases. And moreover, when we trace or when we do the pedigree analysis, they are a dense family. After repeated assessment, symptom by symptom, interview with family members, relative, we were not just able to find the clear-cut diagnostic criteria by CD or by DSM. So that is the reason we thought, okay, let's do a WES and see what comes out. And then the next question is, yes, we have done a WES. We have give a name which sounds very scientific, or rather very medical, for what looks like a psychiatric condition, certain white. But what are the questions that we need to answer at this point of time? So the thing is, when we did it, did we actually open a Pandora's box? If we go to the family tree again, there are two sisters. The GDI1 is X-linked dominant. That means unless we are able to prove that the gene is absent in the mother and it's de novo in the twins, that means four daughters are having a very, very high chances of carrying the gene. The GDI is used in electron transport, stabilizing the membrane, present very much in the neurons. It can be in other area, and the mutation is responsible for some intellectual disability. That is what the database is now. So when you say intellectual disability, probably, then the question that comes is, what can really put us or any physician or any doctor in a very tight spot? Then what do we do? How do we explain? So these are the concerns for the elder sister and the rest of the family members, including the parents. Like, if the twins has a mitral valve prolapse, then what is the probability that the parents, which are no longer young, the other siblings, which are still young, might be carrying it? Is it warranted to ask each and every one of them to do exome sequencing, because it looks very academic to us for what is a very, very expensive test? Their affordability not being into consideration, because I mean, they are fairly affordable, but the question is not that. Are we really justified? So that is the hard part that we have to face, or rather we have to deal when the result comes out and it is not what we thought you would be. So here I'll be a little bit theoretical, because this is, even though it's theoretical, this is something which we will be facing day in, day out, because as the technology advances, the adoption of genetic testing is going to be more. And this is something we have to be aware of, we need to be informed. Psychiatric genetic counseling, what does it do? It's just a process of helping people understand, adapt to the medical, psychological, and familial implications of genetic contribution to disease. Yes, we seems to be going real basic science. That is what sounds to us, but it goes much beyond that. So what are the goals? To understand the etiology, some part of it, at least. Identify protective factors and improving health-related behaviors. Health-related behavior in most of the studies suggests about, increased continued adherence, compliance, only that part, not nothing else. Providing information to facilitate decisions making and to address stigma and psychotherapeutic aspects. These are very, very strong words. The reason I said it is a Pandora's box is because no matter how much there is satisfaction that we are able to find some mutation or some change which can partly or in some part explain why they are behaving the way they are behaving. For science, it is quite good to understand if the medicine can influence some outcome. Sounds good, but a lot of other things comes into question. Human rights, dignity, discrimination, traumatization, the genetic essentialism. We are the genetic people, what we say is right, so you have to follow us. Doesn't work like that. Yet the social stigma needs to be addressed. Then, yes, we have a finding, but this finding, does it really hold to another family member who are asymptomatic or pre-symptomatic? Those are difficult questions. Then when we said that, okay, we have a gene which might be responsible for this symptom or at least this part of the illness, where do we relate to when it comes to prognosis? In this case, the two twins that we have dealt, honestly speaking, we as a team, we can't explain, because even the White syndrome complex is a disease in evolution, very much like Hashimoto's. The criteria are expanding. So when the criteria are expanding, that means more symptoms are being added. And there is hardly any long-term studies for more than 10 years by which we can say that, this may be the outcome. A patient with diabetes, you can say that if the diabetic blood sugar or HbA1c is not controlled, the chances of triopathy in 5 years, 10 years is this much percentage. We still can't do that. Then we have to deal with long-term medical history. Then females, the two sisters, one of them is a medical individual. So a lot of uncomfortable questions from her part also started coming out, that what is the probability she might carry a child in the future with these mutations? Is a perinatal testing worth? These are difficult questions. When we have the genetic information of an individual, or rather a set of individual, it comes with an enormous amount of responsibilities, because first of all, it is a data which is to be safeguarded, and the data can be misused. First of all, misuse in the family, in the sense that, yes, when we have caregivers who are patients themselves taking care of another patient who has a mutation, then the express emotion, the rip in the family will start, because it gives them some sort of an indication that, okay, this is purely genetic, nothing can be done about it. So do we give up? The negative part. Or the other side is, yes, there seems to be some reason why people are behaving, including me, that means the sick caregiver, and technology may give them some hope, which is quite less on the real world. Then when an unaffected family member goes for employment, for service, or anything, a person who has an access to the data can do a lot of things which increases the stigma. So how do you explain, as a very example, that in a patient with Huntington's disease, which comes at late 40s and 50s, to the son who may be in their 10s and 20s, that you carry the same gene your parents carried, and by age 40, you will be doing behaving exactly the way your father is behaving. How are they going to take it? So whenever we do a genetic testing, we require a lot of pre-test counseling, several sessions of post-test counseling, because people will come with hope, people will come with apprehension. So the job, it starts there. It is not just, okay, the HbA1c is 9, so let's add 1 gram of metformin, glimepiride 1 milligram, diet and exercise, and we'll do observe 5 months the same test. Their genes, they're going to be the same. We don't have a technique as yet to correct it. So, as much as it gives hope, it also can give some sort of bleakness. Then when we talk about limitations, let's go a little bit into the technical part about why we call it limited. It is not improved, but most of the genetic testing registry that was done before, based on which we also try to match with our finding, they are based on European-based registry. So there is exclusion of minority communities, there is exclusion of children, there are legal complications, and the techniques are evolving. So children are a very dicey area. First of all, they don't have the capacity to give consent, and the parents decide. So what will be how do you explain the genetic finding to a child suffering from an illness who is young and who is not so young? These are unanswered questions. There are no separate guidelines, no hard and fast rule which says how do you explain, but it is based on more on a very good intention about explaining, informing, rather the need to identify early symptoms even before they set it. So these are some of the difficult parts. The legal complications. Yes, a person with charge for homicide comes and say that, okay, I have this gene which might be responsible for my frontal lobe being dysfunctional, and because my functional lobe is dysfunctional, my frontal lobe is dysfunctional, and because of the genetic error, so I'm really sick. It is when we really get into a legal tangle. Does genetics, or is genetics sufficient enough to warrant a person who has done a crime masquerading as mental ill? Difficult answer. No, there is no real answer now, but it is more on the collection of evidence. I've gone through some of the guidelines which suggest what are the things that we should be looking at when we do a genetic testing in psychiatry. The Americans have their own, the Europeans have their own. I'm just trying to summarize what has been a statement from the International Society of Psychiatric Genetics. This is a body which keeps on updating their database. They share an enormous amount of information with everyone who requests from them. And some of the summary which I'm sharing now, these are updations in the past couple of years. I think 2019 or 2020 was the last update. And after that, nothing much has changed. Right? They say the same thing which we have understood so far, that there are common variants, that there are rare variants, and there is association. And some factors like a polygenic risk score are being used for calculating the risks, but they don't say that there is a clear clinical value for each one of them individually. So presence of one mutation, some polygenic risk score, in absence of significant symptoms, family history, past histories, response to medicine, they are not really holds any value. But yes, it says that, yeah, there might be one. Some of the mutation that we see can be de novo. The same with the twins. None of the brothers and sisters have it, they have it. Is it de novo? Because the mother, even though she might be a carrier, she doesn't have any symptom. Pre-test and post-test counseling is very much necessary for stigma reduction. The difficult part, or one of the difficult thing, is how do we disclose a secondary incidental finding? If we remember our days of surgery, I mean, one of the short notes which used to come was management of an incidentaloma. Either it can be adrenal, it can be renal, it can be hepatic. We were confused what incidentaloma means. It's just an incidental finding, maybe benign, maybe malignant, we don't know. But it tends to generate some curiosity, some fear. So in a person, let's say a proband or the relative has some findings, are you really going to share it? Because this finding does not really indicate anything at this point of time. There are two ways of looking at it. If we remember, we say uncertain significance. I will try to explain what is uncertain significance. Yeah, when it comes to incidental finding. Okay. The technology or the understanding that we have, let's say, for example, base year 2022, according to the technology that we have today, it is uncertain because we don't have sufficient data. Then if the person we said, okay, there is no data, so most likely you are not carrying something which is a disease variant, and he develops a disease 10 years later, then are we going to be sued for saying that it was not a disease variant? It's a possibility which can happen. Then at the same time, it can be just an incidental one, not really significant, and he remains asymptomatic. So here, what they recommend is about just explaining, okay, this is something we have this information as of today, but this information can change. The same explanation for the variant of unknown significance, because ours was a variant of unknown significance. The duplication was happening in the gene upstream, not in downstream. We had experienced similar unknown significance in around 5 years back in a case of frontotemporal dementia in a very young man, and where the progression was very rapid. That gene today is now a part of FTD. So whether this will become a diagnostic or rather a confirmatory or a gene of significance or a variation of significance, it remains an open-ended question. Okay, data safety and privacy is what it has been abrogated. The second part is something which I feel for our Indian setting, for the sake of our trainees, for the growth of psychiatry, it is very much required. All recommendation, the Japanese, the Taiwanese, the American, the British, all of them says that we need to learn psychiatric genetics. I mean, it needs to be inculcated in the training of our residents. they have done a survey in Canada and US, I think Norway or one of the European countries, and the common consensus, or rather the average time a resident spend, or a trainer takes a resident or a trainee in the whole 3 years, or the time of training, is an average of 1.5 to 2 hours max. Not sufficient to understand. So there is a proposal that maybe this is the time we need to integrate, or at least try to improvise on knowing some of the techniques. The recommendation is not that every one of us go to the lab and learn it, but at least the dimension of the syllabus needs to change. Pharmacogenetic testing always has received a bad reputation because it is so much commercial, but as a tool for a good clinical care, it can also be viewed, right? So this is basically the summary of the recommendation. So the conclusion is very much what the summary says. I mean, psychiatric genetics is very promising. It seems to be one of the way forward for us to take psychiatry forward, but we still lack in technology. Complex traits are there which are not necessarily explained by genetics alone. There is epigenetics, there are other things which will influence even the presentation of some mutation which may or may not give rise to an illness. And yes, I completely agree that there is a need in every one of us to learn the basics. So I have not used a lot of reference. These are some of the good ones which I came across. The remaining I can share it through the group or through the bussing team, and which can be circulated. There are around 10 of the really good articles. And I will end with this motto: let's learn together. That's it.
Thank you, Dr.
Great,
Sidney.
great.
Thank you, Dr. Sidney. That was quite a comprehensive talk, clinically based. We'll take up some questions now. Ashutosh, please do the honors.
So I'll start by the first question, which has been sent by Dr. Payal Talukdar.
You can stop the screen share, please.
Okay, stop share. All right. Okay, yeah, thank you.
So her question is, when one child is suffering from ASD, what genetic counseling we can do when parents are planning for a second child?
Very, very honest answer. We really don't have a guideline in India. Neither do any of the society which is looking into the endophenotypes, the phenotypes, or even the genotype of ASD. First of all, the classification of ASD is evolving, right? And yes, if we have to theoretically say, purely theoretically, yes, one of the child is autistic. I mean, yeah, you can do a sequencing to see whether the pathology which your child is exhibiting is a genetic correlate. If there is one, then theoretically there might be a probability the second may have, but our psychiatric genetics does not follow the straight Mendelian inheritance about one gene, one hypothesis, one disease hypothesis. It skips generation. The penetrance can be different, the expressivity can be different. And so in the same way, half of the genome comes from the father. If the father doesn't have it, so there is more than 50% chance you can't. Yes, curiosity is something, there is no straight answer. And this is an area which has been dealt by obstetrician, which has been dealt by pediatrics, which we will be dealing it shortly. There is no real true answer. Yes, to satisfy your curiosity, you can do a lot of expensive panels, but yes, theoretically the second child has some mutation. If he doesn't develop the syndrome, then was the risk worth it? So no straight answer.
ASD has one of the highest heritability amongst all psychiatric disorders, almost to the tune of 85%. So even without a genetic testing, would it be prudent to just inform the parents that the risk for a second child developing ASD is much, much higher? I mean, would that be correct?
Yeah, that will be correct. But when we say risk is higher, then the ethics part of it comes into it. I really appreciate you asking this question, because when we say risk is higher, are we telling them you go for adoption? Are we telling them that you cannot have a second child? Are we telling them your first child is what it is? So the answer that we give, even though we know that yes, there are the heritability is quite high. It is one of the most studied disorder, but it's also one of the, you can say, the most abused disorder. I mean, there is no straight answer.
Okay.
Yeah, we have another question. This is from Dr. Alokik Agrawal. He says, he asks, what will it take and how long it will take for genetic testing for drug response in psychiatric disorders to become mainstream worldwide and in India?
Okay, all right. Alokik, I'm really great you asked this question. You have been one of us. So let me start with the biology of addiction briefly, because you have done something more than us. Do we really understand what are the genes we are looking at? I mean, is it really the pathway that we are looking at? So yes, some of the cytochrome genes that we understand, which we already know from fluoxetine, Flovox. I mean, that is the first thing that has been taught to us way back in our MBBS. From that time till now, except for some panels, some arrays, things have not really changed. So yes, precision clinical medicine seems to be the way forward, but at the same time, the good part, or rather the difficult part about psychiatric genetics, is the technology as well as that understanding is also evolving. So what we thought is a panel of a gene which might be looking at, let's say, the metabolism of, let's say, naltrexone in a person with so-called behavioral dependence. Today, when you develop the panel, by the time it is marketed out, something else may come. So yes, theoretically it is good, but to say that it is becoming mainstream, none of the guidelines recommend it. At least the Consortium for the Psychiatric Genetics doesn't do it. The American doesn't do it. NIMS doesn't do it. Many people have their own interest of promoting it. I mean, there are a lot of companies who sell chips saying that this is what you can do even over the counter. And there are chips which are actually available over the counter. It can be done just like what we did for COVID testing. But it doesn't answer.
Okay.
There are actually, I'll club these two questions. Dr. Devai had asked what would be the indications to do the genetic testing. You did show this early on in your slide, as well as a question by Dr. G.V. Ramana Rao, that what are the specific indications for pharmacogenetic testing in psychiatry and how cost effective they are. So if you want to show that slide again, which you had shown in the beginning of your presentations, I think it may help the audience.
Is it visible?
Yes, now it is. I think it was the 5th or 6th slide in your presentation.
Okay, I will just give a very personal opinion why I have not really gone into drug response, because as much as it sounds very fancy and nice and lucrative, there is nothing much more than what we already knew. I mean, the techniques has been refined. We know that serotonin transporter has been involved, but it is also involved in depression. It's also involved in suicide. It's also involved in so many things. So the definition of an endophenotype or an intermediate phenotype becomes so variable. So there is a reason I have not really gone into it, because yes, it is very, 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 very lucrative from a business point, maybe in a good way. But when it comes to a scientific one or a research one, still some way away.
So can we answer it this way, that a person who is not showing a response at an adequate dose or is showing an unusual adverse event profile, may be a candidate for pharmacogenetic testing?
Definitely. I mean, those are the actual candidate. I mean, but if we again try to see from the illness profile or even from the family history, that might also explain some part of it. This is also the reason I have chosen MSL for both twins, because one respond, they are monozygotic. So it was based only on the clinical principles. They respond sometime, then after it plateaued out. Yes, from a theoretical possibility, whether we look for carbamazepine, oxcarbamazepine, hypersensitivity, which is one of the most well-studied, yes, we can. But unfortunately, this is an area which is commercialized and exploited more than what the science can do.
Okay. We have somebody who identifies as Zoom headquarters USA, and this individual asks, what is the role of exome genome sequencing in neurodevelopmental disorders, and any screening implications for psychiatric illnesses in future? I think you have gone through the points, but if you just summarize in brief.
Yeah. So let me just, okay, theoretically, it promises quite a lot. I mean, yes, when you know that, let's say, for example, in adverse childhood events, the hypermethylation of the serotonin transporter gene, which is not bringing out the serotonin transporter, might be responsible for a person developing, or rather becoming resistant to medication. So you do a CRISPR and probably you can enhance it, but that is more of a theoretical thing. Right now, all the work which the researchers are doing are based on some of the area of interest, some of the brain regions. If we go very theoretical, when we say exome sequencing of a particular person, we are just looking at the proxy markers from blood. We have not done a brain biopsy. If we remember, every cells in our body, whether it is bone, blood, hair, we carry the exact same gene. It is just the way they are expressed as an organ, it becomes different. So a frontal lobe, ventral tegmental area, basal ganglia, the same gene can have different expression. So we need to consider into what is the reason of interest, or what was the question which the investigator or the researchers have asked, and what is their conclusion. Yes, the conclusion also holds true for if we see the illness from the DSM or the ICD based symptom related. But when we club into is it reason or specific related, then this is an answer we still don't have. Like for diabetes, we can say that diabetes is diabetes, whether you call it MODY or whether you call it type 1, type 2 or type 3 or MODY 10, you give insulin or you give OHS, it works the same. But we tend to refine diabetes, we tend to refine Ehlers-Danlos syndrome from 9 to 13, even more in the future, based on our understanding, even though the etiology or rather the management will not change. So from that perspective, yes, exome sequencing promises a way forward, but again, it also depends on what is the reason that we are looking at. Are we looking at a proxy marker, or are we looking at a tissue-specific marker? So the tissue-specific marker is the one where most of the limitations arise, right? Like we do methylation studies for bipolar patient taking blood, so being a proxy marker. But how much this will correlate with, let's say, a sample of the hippocampus or sample of the frontal lobe, honestly, I don't know. I mean, we have not done that. This is the yes and the no both.
Okay. Yeah, Dr. Divay has asked a question, which says, we might be missing many subtle neurometabolic and mitochondrial disorders presenting as psychiatric illnesses. Will genetic testing help in this?
Definitely it has. I mean, if we look at the very famous Dijor syndrome, I think this is one of the most famous disorder which has been related to us, and where the management is even implicating that we change towards bioenergetics as add-on, if not the primary therapy, in addition to the usual traditional antidepressant, antipsychotics that we use. So because the latest finding shows that the ATP generation is actually quite low in the neurons, particularly in also the glutamate pathway. So theoretically speaking, yes, glutamate should have helped, ubiquinone should have helped, but in India, we don't get the dose that the clinical protocols or the clinical trials that are being done out. So, I mean, yes, we are going in that direction, still not yet. So there is also the reason why I had tried to see on the logistics or the difficulty of the presentation rather than discussing what are the techniques. I mean, this is the real thing which we will be facing day in, day out. Technology is in fact evolving. At the same time, the limitation is also what we need to be painfully aware of. We have to be very honest with ourselves at this point of time.
I have one question from my side. May I ask?
Please, Astose.
I mean, in the twins, the case that you presented, perhaps I may have missed, but after the genetic testing, what was the change in the treatment? Because both were on SSRIs and amisulpride.
Yeah.
Perhaps I missed it if you had presented, but I didn't see any change in the medications after the genetic testing.
Yeah, this is purely on a, should I say, one of the leap of faith that you take when you look into the report of other co-workers who are trying to treat what we understand as schizophrenia or behavioral addiction or addiction differently. Can we go into the bioenergetics pathway? Can we go into the gut microbiota? Can we alter there? So I would not like to say officially in this channel, but we have used a fairly high dose of L-carnosine, more than what is recommended. And the same with the gut microbiomes. So these are some of things where the study done by people elsewhere is preprint. They don't generate statistical significance because the sample size is not high enough, but at the same time, they found some usefulness. So whether some of the improvement which the twins have shown after adding these two, is it a part of the same cycle that initially there was some response, they improved, then it plateau out, then again it improved, then plateau out. So is it the same cycle which is continuing in a different way, or is it the same thing? Some maybe 2%, 1% attribution to this add-ons. So only a follow-up will be able to say.
Okay.
But with that addition of the, I'll just take it from Ashutosh, with the addition of carnosine, and I think the gut micro culture or whatever you gave, was it? I mean, initial rushes. Are the patients doing well?
They are doing well. The cost was a factor, but since the family could bear the cost, so that mitigates some of the misgivings which we had with this molecule, because we also use L-carnosine in a fairly high dose when with a vascular dementia in a young individual less than 51 or 52. So, I mean, we could find some improvement. At least the person became a little bit more trainable than what he was. It may be the process stop, or it may be it has helped stop, or he is beginning to learn. I mean, there might be multiple factors, but so based on those very, very tiny cohort, or rather anecdotal reports, seems to suggest. I mean, this is purely my personal observation. I can be 100% wrong.
We have one question from Dr. Subhas Pradhan. How far can we predict about pharmacodynamic interactions through genetic testing? Pharmacodynamic interactions.
Okay. Honestly speaking, I mean, when we say pharmacodynamic, we are going into the area of epigenetics. So prediction here is a very difficult question. So when you say the drug response, let's say to the same serotonin response transporter, you know that, okay, you do methylation studies, you found that the promoter is hypermethylated, so you give an SSRI or a TCA, then it opens up, then the transporter comes out. So that way, as long as the medicine is going, it's going to be there. But whether this improvement, or rather this hypermethylation, is a trait or a state, that is the question which neither pharmacodynamics, neither epigenetics is able to answer at this point of time. So that is the reason when it comes to drug testing or personalized medicine, I still have my own skepticism. Theoretically, yes, but long term, I have to be very honest, I'm not sure.
One more question from my side.
Please.
So I was quite enthusiastic before this meeting, and after hearing you everything, Dr. Sidney, I'm a bit now apprehensive, I would say, to advise genetic testing. I've never done it so far in my career because the questions you showed on your slide 33, the implications which come about and other things. So what happens is, I will speak for myself. My knowledge of genetics is very much limited as compared to an institutional level research team. Secondly, I don't know what to do after I get the results. You showed those two indels and copy number variants in this twins that you got. Then you all figured out you all have to give carnosine. I may not be in a position to do that. So what do I do with the result other than satisfying my academic curiosity? And then what about the implications? Because often, it involves testing the parents, the siblings, then questions like you said, one of the medical sisters of the twins, she was apprehensive whether her children will get or not get, and then potential future lawsuits. So honestly, would you recommend the standalone private practitioners to venture out into this area, or we still wait for some much more concrete, I would say, guidance is coming out?
Dr. Sudos, I will be very, this is my personal opinion, based on some of the things which most of the guidelines is. Okay. They did a survey in Canada about the same thing. They did a similar survey in Australia. The attitudes about practitioners when it comes to advising on genetic testing. So this is a common fear. But if I'm trying to explain from the positive part of why we can do it. Right? I mean, people can do it for a number of reasons, but for a very scientific, rational, positive thing, most of the tests now, it is not very complex or unexplained what we had 5 years or 10 years back. GWAS sounds very fancy to write as an essay to pass your MD. I mean, it looks very big. But when we look into what are they looking at, I think what I experience will be experienced by most of our friends. It looks Greek, Latin to us. Right? But if I didn't hear the whole report, but they have given an elaborate explanation of what exactly these things are. I mean, they have given very, very elaborately. So they also said uncertain significance, insignificant, not significant, what it means. And the good part of the beauty is, first of all, nobody, no patient wants to be told that you have schizophrenia because your diagnosis is schizophrenia. You are hearing a set of voice which the grandfather, the local priest, or the Maulvi says, Bhagwan pe bharosa rakho. I mean, they are already in trouble. It is not something they're imagining. So when we give them that there is some medical finding, we don't say necessarily genetic, which is probably trying to explain why you behave the way you behave. And this is where the drugs are actually working. The confidence boosts up like anything. For the twins, they are young. I mean, we don't have the courage to straight away tell you that you have an MVP, because this MVP can progress as well as it can be just static, and there is hyper intensity in the frontal lobe. But the confidence, they have been boosted that, okay, there is a cause for which there can be a cure, because first of all, there was nothing, then there is something. So the work in progress, what we call is a work in progress, in the sense that you do the testing as well as our understanding improves, is what has been suggested is the way forward. Because fear of any test, whether it is a test of an MRI or a angiography, they have their own negative pitfalls. So that way, our testing is not different. Whatever is the legal consequences, the same legal consequences goes for an angiography in a person with angina. By the time you do the angiography, the angina is gone, there are no blocked arteries. So the doctor can be charged that why did you do that? It's not exactly as simple as for us. So there is nothing wrong in it. Trust me, there is nothing wrong in it. Exome sequencing, the cost has dropped to, people might throw bricks at me when you say drop to. Now it's around 11,000, 12,000 odd. When Dr. Jain, I'm not sure whether sir is in this presentation, when he started the genome sequencing way back, one testing was 65, 75,000. Unless you are a part of project, it was almost something you forget. You go to some presentation where the Westerners show some fancy slide and we clap and come back. The cost has dropped like anything. If you see the heavy metal testing, mercury and lithium, which has practically no role in autism, whatever, it was fancy, they cost 8,000, 9,000. So I'm not justifying that, it is cheaper now to do it, but the actual cost is done. So when more people order that test, it again is a market-based demand. The more you do it, the cost will drop. So what is 11,000 can be maybe 2,000 or 3,000 or even less, maybe 2 years from now. And when the exomes are more explored, or when the genome, the entire panel is there, so there is nothing wrong in it. How we use it also depends on our own sincerity, how we are explaining. So yes, there is something. There seems to be a lead forward. And if you use the medicine, one thing which they have talked is about follow-up and adherence. The moment we say there is a finding, people's confidence also increase. Now this medicine is likely to be working. Yes, it does not will work when a person is completely psychotic and fraudulently deluded or hallucinating. We are not talking of those individuals, but once they are in a position to understand what exactly this testing means and what these findings are in the best way we can, then our sincerity shows. Anyway, as a mental health professional, we spend a lot of time. So that has been the common feedback from Australia, from Canada. We are no different. There is nothing wrong in it. If you feel the person like presentation is odd, there's no responding, there is nothing wrong in it. Please go ahead.
Dr. Sidney, I have a couple of questions from my side. You are at an institutional level, probably doing much more genetic testing and counseling than all of us combined together here. What kind of a consent do you take from patient relatives? Because you mentioned, even Ashutosh mentioned in this question, and again, we are discussing the same thing: ethical issues, legal issues, uncertainties as to how the whole thing will evolve in the future. Different things will crop up or remain stable. We have no idea. So do you take a kind of a, I mean, are these points included in the consent?
Yeah,
and
it is
do you have a disclaimer for that, that this is the current state of affairs and we do not know, so we'll forget about anything happening in the future and we being responsible for that kind of thing?
Yes, sir. Let me explain. One, the testing that we do as a part of the project. Okay, because there are a lot of projects that we learn, and the project bears the cost of the testing, or at least a part of the cost. So the consent there is extremely elaborate. I mean, it satisfies all the criteria. One is the clinical that we use day in, day out. It is also there, where it is also clearly explained to the patient, the family, what is the tester, the lab. They also have their own consent. I mean, it is not just you call Rinvaxi, by evening the person comes, draw blood, goes away. It doesn't work like that. They also take a very elaborate history, all the, at least what to call, documentable evidence or some of the safeguards which are necessary. It is being taken. I cannot comment about every other institute who does that or every other person, but at least from our side, we can say that we are trying our best to maintain it.
Yeah, another question that I had was, you mentioned that one of the limitations of testing currently in India is that the data that is available is mostly Caucasian or European.
Yeah.
So do we have comparable Indian data or Indian different populations in our country?
Sir,
like a bank of,
okay,
which you can
right.
fall back on.
Yeah. I think if I remember the last count for ADBS and this one, CBEDA, I think we have around 10,000 blood samples, not process samples. So maybe the next few years, we might be able to come up some. Imaging is more than what we have for the genetics, because what we usually do in all these projects is, one, you take some part of it, process it, look at what you look, and you store the remaining at -80. It's very expensive. It's very, very expensive. So we have numbers comparable to some of the centers which are there in other places. But sadly, getting the money to do it is the challenge. So, and again, to explain to a lawmaker why this is necessary, it is a different level.
I think we have regulations, very tight regulations about genetic testing. We cannot export the sample.
Yeah.
I doubt that we can have a kind of a open access genetic database for Indians.
Okay, when we say database, one is, okay, you sequence 100 people with all the technology that we have, and without identifying markers, you upload it. Even PubMed, if you go to PubMed session, the usual search that we do is the mess. But if you go further, there is something known as BLAST. Just make a sequence, any random sequence, put it, then they will tell you whether it's a human, a bacteria, or something like that. So it is, the data is already there. The actual blood or the specimen is the one you cannot take out. No country, unless there is a huge clear understanding between researchers and country, might be possible. Germany is very particular. You cannot even touch it. I mean, that way, India also does it, but the process data you can. It is what is being shared.
Okay.
Okay, so there are a quick couple of yes or no questions for you. So one question comes from Dr. Karanjit Singh. Recurrent first trimester abortions would it be an indication for prenatal genetic testing? Yes, no?
Definitely, yes.
Okay.
There is the basic indication we should be doing.
Second, yes or no is, will testing help in knowing comorbid physical illness, which go hand in hand with psychiatric disorder and hence help in choosing medication?
I will answer the probable part, taking our case as an example. White Shooten syndrome has a lot of optic anomalies, ranging from anomalies of the lens, the cornea, the retina, as well as a visual error. One of the twins have it. So when he was complaining of headache, which looks like tension, and when you do the testing, it came out to be a refractive error. So that way the testing can help, but this is a very tall claim. It can be any other incidental one. But if we see the symptom profile as a whole, it seems to have helped. The MVP is there, so at least we can, or rather we have advised the family that it is not a very severe MVP. People can have MVP due to multiple reasons, symptomatic, asymptomatic. So it is always prudent that they go for an annual checkup. So that way, yeah, it helps. But will it help for every comorbidity? That will be a little too far.
Last two questions. Which test or tests, if any, is clinically useful as of now for a routine clinic from your experience?
Okay, from our experience, the whole exome, because
Okay.
that is much cheaper compared to whole genome. The whole genome still costs around 28 or 29 or 1,000 in advance. Exome is even outside is just 11. So you can do 3 exomes compared to a.
Okay. And another last question: what is the cost in government hospital and private hospital for genome testing? I think that is what you have answered just now.
Yeah.
Okay. So now there are no more questions on the chat box. Ashutosh has one.
So those twins, at the end of the genetic testing, why did you all not change the diagnosis to White Shooten syndrome? Because
we have changed. We have changed. That is the reason I said that diagnosis is an evolution.
Okay.
Because I mean, when we compared all the diagnostic features that has been reported, some 100 odd cases all over the world, the density was for 12 families, and according to the comparison with all the things reported, they seems to have a milder one. And based on that, yes, they have a safer diagnosis. That is White Shooten. But whether every schizophrenia or every OCD will be White Shooten, will be part of the loss of heritability that we always talk about, because we are not testing enough.
I mean, if every practitioner in India starts doing genetic testing, we will eventually,
definitely, yeah,
we'll kick out ICD and DSM, because then we'll have the names for what is happening to them.
That is when they have suggested the reverse phenotyping, the reverse classification. I mean, why not we classify the disorder or a set of disorders based on at least the imaging or the genetic finding or some, metabolic findings. I mean, I think that should be the way out. But at the same time, we have to be very, very honest. Like I said, all the testing that we are doing are proxy markers, blood, saliva, hair. Brain sample is still a very difficult area. I think Professor Jain collected in his 40 years career maybe 12 brain, which we could lay our hands on. Trust me, even in a place like Nimans, it is very, very, very difficult.
Okay. Yes.
Sir, I think we are through the questions in the chat box.
Yeah, we are through with the questions. We'll just have a bit of end notes. Ashutosh, you begin.
Sure. I think it was nice, and Dr. Subhas Pradhan, whose post has been endorsed by Dr. Malay Dave, he has summarized it succinctly to say that we are just scratching genetic testing in psychiatry, and as of date, we cannot recommend it like, antibiotic sensitivity testing in every case. So we have to be a bit selective. And of course, I think it's learning by experience and learning by doing. So you did allay to some extent my anxiety that, it's not that you should not do, you can do it. And a little bit of hand holding, maybe we will approach you if we ever do it to know, how do we counsel, what do we do after we get the results. But eventually, once, people start doing it, we can be actually kind of mapping the phenotype to the genotype, and then be able to actually have much more, I would say, rational treatment, at the same time giving advices to the family members. So overall, a very nice lesson. And I actually discovered that nuclein, which is the precursor of what was later on labeled as DNA, was first discovered way back in 1869 by Friedrich Miescher, a Swiss biochemist and a doctor. So it's high time, I think, close to quarter to 200 years, much before Freud, that the DNA was actually discovered. It was not Watson and Crick who discovered. They discovered the 3D model.
Yeah.
So I think the audience who are still holding on, listening to us, should now at least appreciate that genetics is something far advanced than psychoanalysis. It came before psychoanalysis. And it's time that we start understanding basics of genetics, start doing things, though we may not be all at the same level. But I think the way forward would be to go and venture out. At least one case in our entire career should be sufficient for us.
Thanks, Ashutosh. And from my
sir.
side, excellent presentation, Dr. Sidney. We would love to have you talk more on this and maybe
Yes, sir. I'll be honored.
fight over it on our groups and all. But from my side, I'm quite enthusiastic to learn new things, and I promise I'll keep up to that. Thank you so much. Over to Dr. Ali.
Thank you, sir. Thank you so much. Sydney, a few observations or you can say comments. Before we come to psychiatric genetics, I think we need to learn genetics, as Ashutosh Bhai said. So basically, the problem is you order a test, you get a result of psychiatry, you get a result with this number of CNV and this mutation, and we don't know what to do of it. So first, we need to build a base. I think people like you should teach people like us that what is exactly genetics, what is psychiatry genetics, and what to do. I think we can start by making a 3-generation family tree. In our practice, we don't usually do that. We just take a verbal history. So when we teach the students, we emphasize on this 3-generation family tree and what are the disorders there. So there you get a picture that this genome is being transferred and it is now in the person. Now, another problem is the results that you get in psychiatry genetics. You will not be able to corroborate directly with the a-theoretical classifications. It is by definition a-theoretical, and we are now going into the theory or the causation. So this is a chasm. This is the gap that has to be filled up. So how we view the disorders, that has to be changed, that has to be modulated, evolved, and that has to be brought at par with the recent updates. So I think much of the hard one will stop if we all try to bridge this gap. So those are my observations. And thank you so much for such a nice presentation. Over to Tufan sir for your comments, sir. And I think you have to say thanks also because Amrit had to leave.
I shall do both the things. I shall start with the thanks. Thanks, Sydney, for this enlightening deliberation. It is highly informative and quite enlightening.
I'm honored, sir. I'm honored, sir. Alim Bhai, let me share a very personal experience. I mean, my journey, or rather, my journey in the Dr. Zain started 2014-15. We were also very afraid because in those 3 years in BGI, wherever you were, genetics was something you read in a long case just before your exam. And how do we do it? What is the PCR? We learn PCR in microbiology or pathology and finish it. But once you step inside a lab, hold a pipette, do it 2 times, 3 times, the whole 96 hours process becomes very, very easy. It is time consuming, it's a little tiring, but 2-3 times you do it, then you can actually visualize what is actually happening. So it is not really that difficult. Trust me, it is not difficult at all. It is just that some of us need to spend maybe minimum 10-15 days in a lab, not the whole 10 hours, but just to get a hang of the basics, what actually happens. Because when we read a paper that we have done this sequencing, we have done this paper, we have used this paper, we extract this, when you actually observe it, then it flows. Just like when we watch a very nice movie. So once that initial barrier is crossed, we are all MBBS. I mean, we have passed out. So recollecting it is not really difficult. It is just like we play table tennis when you are in 10 standard, and we try to play to when you're age 40. Yeah, the hands are not fine, but after 2-3 matches, it becomes sharp.
Thank you for boosting our morale.
It's very much possible. I mean, we can in fact, start working towards it if possible. This is also the whole idea when I was really thinking till yesterday evening whether I should present this topic in a very theoretical talk about NSGs and all the pros and cons, or whether we actually discuss the real challenge which we face in daily life. So that is when I changed the whole format. So it is doable. Trust me, it is not something elite or unachievable. Nothing like that. If you are in a medical college, physics, pathology, immunology, spend some time. It's doable. Trust me.
Thank you, bhai. Thank you. Tufan sir.
Thank you again for your inspiring inputs, additional inputs. And I hope most of the audience with definitely limited knowledge of genetics, if they are like me, they admire the fact that genetic testing has a place. But simultaneously, the legal issues related to it concerning the autonomy of the patient. All said and done, the patient has the right to withdraw the information about him from anybody. And that does not hinge upon the fact that we are doing it free of cost.
True.
And if we get a consent on the basis that we are getting it done free of cost, that is why you have to give consent. You are unduly, immorally leveraging our higher position on it. So that is about autonomy and the privacy. All these things are important when we develop we have to develop a guideline, a method, how we can go with this. Accepted on one part, we can get the test done. If we are intent upon it, and we can develop it because we are doing many things. And science is advancing very fast in India also. But these parts have to be taken care of. Otherwise, tomorrow we can have a patient challenging us. Just like telling that in the police station, police took the consent by force. Maybe this is a professional hazard, we will face it at times. But we have to have developed way to how to educate the patient, the number of counselings we do before and after, how to organize it. Maybe we have to have some exercise on that. Because genetic testing is quite admirable. Everything is, for us as scientists, appears appropriate. But the person at the taker who is at the other end, as Dr. Asutosh was telling, whether can we develop that Indian shop this pattern of? Because we have to take into consideration these people from this tribe have got this. And they have not given us consent to publicize their material against their names. And someone can challenge this. And it is ethical also. So these considerations have to be kept in mind when we think of developing the ways. But efforts are commendable, result is commendable, your case presenter, case dignity was highly explanatory. And at times I'm enticed to tell that, okay, go and talk to Dr. Sydney in advance, whether he can do something about testing. I am not advising, I am advising to consult him. So legally to and thank you very much, Sydney, again. Thanks.
It's my honor, sir. It's my honor.
Thanks, Dr. Asutosh, for your enthusiastic and rich inputs to this program. We are honored. And Alim is my friend, philosopher, Hamshafar hai in Thursday music. The last one, suffer because he has an urgent work, he has gone out at assembly. On behalf of the total Thursday music team, thanks everybody, thanks all the audience, and thanks Torrent for providing us the platform.
And thanks to Dr. Malay also. A big input from his side.
Yes, I have thanked him also.
Yes.
Thank you. Thank you.
Yeah. Thanks to both the chairpersons. I think they were so enthusiastic that I was just keeping silent and letting them do all my work also. So
Dr. Malay is always enthusiastic.
Yes. And in fact, Dr. Ashutosh said that he will not leave this session even if some other session is going on. So yeah. So he said that he will definitely join this. So thank you, Ashutosh bhai. Thank you, Malay sir. Sydney, thank you so much. I think you need to come again and teach us again, because
what I shall suggest, Dr. Sydney, to what you told that you come to the lab and see like a movie, you can have a excerpt of that movie designed to be presented in Thursday Musings.
We can work on this.
Walk in the lab.
I
Yeah.
believe that will be highly educated because one has to know what is really happening in the lab and what Dr. Sidney is writing and what is being done.
So it is done by our lab team. I mean, we don't go that frequently. It is just, yeah, we have learned the techniques, but there are more better qualified people, because the moment you use the pipette and you put more, put less, gone. It will be 5,000 down the drain.
So,
Okay.
thank you, sir. Thank you so much. Thank you, sir. Sir, with your permission, can we close the meeting now?
Sure.
So once
Good night,
again,
everybody. It was
Yeah, thank
really
Good
a
night, everybody.
privilege.
Thanks, everybody. See you. Bye-bye.
Sidney, there were
Ashutosh,
many
bye.
compliments in the chat box for you. We could not read all of them, but there were many compliments, and everyone is quite happy with your presentation.
I am really honored. I thought I was trying to make some understanding, some simplifications. So if I'm able to achieve that, it's my honor.
Thank you, sir.
And you are expected again. And if
I will do
possible, if possible, in my way, my suggested way.
But I think Dr. Mala and Dr. Ashutosh can also be there,
Yeah.
because they are very knowledgeable persons.
We can have real fireworks with also Bhaskar.
Yeah, sure.
Sure. Yeah.
We can have a panel on this and this.
It makes sense. This should be a discussion in a conference rather than over a Zoom meeting, because it is always by the unidirectional most of the time. So
Yeah.
this is something we should be in a hall rather than me reading out a case vignette. I could have stopped somewhere and asked the students or any of the or audience to say what could be the probable way forward. So that was what I was really hoping.
You can have it. You can have also opinion poll. We can have it if you design. Want it, we can do it in the further sessions. Anything we
Sure, sir.
want to do it.
Sure, sir.
Thank you. Good night.
Hello. Thank you so much. Thank you so much, everyone. Good night. Closing the meeting now.
Bye bye.
Bye.
Bye bye.